There is another very interesting case who is again a 70-year-old man who has a long-standing history of smoking, 25 packer smoking history, and he presented with 2 months history of undocumented weight loss, general ill health, and emaciation. Now, if this patient chest X-ray, if the first chest X-ray on presentation of this patient is this one, look at this. There are many findings. The first abnormal finding which has been because of a technical error is actually the patient X-ray has been labeled wrongly. This is the left side of the patient and this is labeled as right sided. So be very careful while interpreting the labeling of the chest X-ray. Always clinically confirm that the patient has lesion or abnormality or pleural effusion or pneumothorax on the side which is labeled on the chest X-ray. So this patient has massive pleural effusion on the left side which is pushing the mediastinum to the other side. Look at the trachea. The trachea has been pushed to the right side, the mediastinum has been shifted to the right side, and there is floating lung just because the patient chest X-ray has been taken in supine position. Now if you look at this chest X-ray again, it is a SAM reflection, and because it is now correctly labeled, this is the right side and this is the left side. This patient underwent chest thoracostomy yesterday, and you can see that this patient has developed hydropneumothorax. This is the hyperlucent area which is divide of the vascular markings with fluid here. So this patient has hydropneumothorax, and if you look at this area is widened, and again the mediastinal has been pushed to the other side. If we focus the right CP angle, it is blunted here. This blunted CP angle indicates that this patient has pleural effusion on the right side. So remember, a patient who has pleural effusion on the left side or the right side which is massive, think about the neoplastic process, particularly if the patient is having a risk factor like smoking or biomass exposure or some other reasons. So this patient underwent chest thoracostomy and he has a CT scan which is clearing the picture further that what is the underlying cause for this pleural effusion. If we focus this CT scan, we can appreciate some pleural thickening here, but the main thing which is important in the clinical context is actually the central lesion which is cavitating. Look at this. This is a central lesion which is cavitating and it is lying central. So central lesion in smokers is squamous cell carcinoma and it is cavitating. If we focus down, we can see the fluid. There is pleural fluid here, there is pleural fluid on the right side as well. If we focus, the mass is appreciable here as well. If we go down, we can just see that this mass is lying in front of the main bronchi. You can see here, you can see it here that this mass is lying in front of the main bronchi, which may cause collapse of the lung. We will just take another scan, another mediastinal window of this patient which will further clarify the picture. Look at this. This patient has pleural effusion on both sides. This is the pleural effusion, this is the pleural effusion, and this is the collapsed lung actually. This is the collapsed lung, this is the pleural effusion. If we come down, look at this. This is the pneumothorax and this is the fluid. So level of the pneumothorax with fluid is the hydropneumothorax, and this is the collapsed lung. If we come down, we can see the pleural effusion which is more marked on the left side is also seen on the right side, and that can be appreciable in chest X-ray as a blunted CP angle. Again, there is a very classical picture, a classical finding which is called the pleura split sign, that you can appreciate the parietal pleura. Focus this is a parietal pleura which is appreciable here, and this is the visceral pleura. So the parietal visceral pleura have been split by the fluid, and this is almost indicative of complex pleural effusion or empyema We can come down to look for the secondary myths in the liver. They are not appreciable here. If we focus on the vertebrae, we cannot appreciate any bony abnormality or erosion. So this patient sounds to be a squamous cell carcinoma secondary to the long-standing history of smoking, and these patients need chest intubation that is already done in this case, and need to wait for the then there is another very important thing which I left in the this is actually the parenchymal window. Look at this. You can appreciate the hydropneumothorax, which is very clear in the parenchymal window. The level is appreciable here. This is the chest tube, and you can see this area is enlarged. Probably this is the tumor which is causing all this. There is another lesion which is called the pleural based nodule, is also appreciable in the previous scan which I left. Look at this. There is a pleural based nodule as well here. So all this go in favor of neoplastic process, most likely the squamous cell carcinoma. Thank you very much. Thank you very much.